Well, good afternoon, folks. Good to be with all of you. Thank you for being with all of us in this interesting time for our state. My name is Michael Tipton. I'm the president of the Blue Cross and Blue Shield of Louisiana Foundation. We are glad you have joined us for our Healthcare Human Capital convening. That will be 4 sessions each Tuesday in September discussing one aspect of addressing Louisiana's healthcare human capital needs. I'm going to start with some housekeeping items. We have all been quite familiar up to this point in time with Zoom. So I'm sure you all are familiar with how to use the chat feature. As you have questions, don't hesitate to drop them in the chat for us, for those on Zoom. For those who are watching us live on Facebook, you are certainly welcome to do so there as well. We look forward to getting to your questions here in a bit. I should start by acknowledging that this was not the set of circumstances that we envisioned when we set out to host these convenings a number of weeks ago. Last week at this time, Louisiana was just coming out from the impacts of Hurricane Ida. I know I was venturing to my house, which a week ago was without power, a few days ago was without power. I know many of our friends across the state are still getting power and internet back. And certainly we know we don't have everyone on hand who would have otherwise been had we not been impacted by a hurricane. As I'll touch on in just a second, that includes some of our friends at the Louisiana Department of Health who are out and about doing hospital assessments and otherwise meeting some very immediate needs. As has often been the case in Louisiana, we have to find ways to navigate and persevere through challenges. At the Blue Cross Foundation, we announced a $5 million commitment late last week to Hurricane Ida relief. We know many other businesses and partners are doing the same. And certainly we have all seen in this last week how those who work on the front lines of healthcare, our nurses and our doctors, have been impacted by the storm, in addition to this past almost 2 years of impacts relative to COVID-19, in addition to all the challenges we're going to talk about today. So certainly this is not the set of circumstances we envisioned, but we are glad you all are here. And we think this last week has made it all the more clear that there are real challenges in healthcare human capital. And so we're glad you're joining us to talk about these important issues. At the Blue Cross Foundation, we are a grant-making foundation committed to improving the wellness and well-being of the people of Louisiana. We've done that in a variety of ways throughout our history. And the last number of years, we've really started to focus on access to care and access to healthcare human capitals. We know that your ability to find a doctor, a nurse, a mental health provider was challenging and is challenging in rural areas, in low-income areas, and high needs areas. We know that with the impact of COVID-19, those challenges got even worse. This unrelenting 18 months has led to burnout, to people moving to new roles, to people just feeling like this is not the field for them. And now you add on top of that a hurricane and many places having all the additional challenges. There are big gaps in direct care. You all have probably seen our state's request for something like 6,000 frontline healthcare workers, a very big number to meet this immediate need. But certainly we know that those numbers were there before the pandemic and before hurricanes. And these are issues we really think we have to solve over the long run. All of this adds to obviously the broader picture that healthcare human capital jobs are good jobs, good opportunities for families and communities. And we've really got to think about how to address these issues collectively. That's what brings us to today, which is an opportunity to really try and position Louisiana to look at the challenges, what's working, what isn't, and a plan for tomorrow so that we are in as good a position as possible to address these issues over the long run. We have a quick graphic. If we could pull up the pipeline or funnel graphic. Over the course of these 4 sessions, over the course of the next couple weeks, each Tuesday at noon in September, we're going to look at a few topics that interrelate to issues of healthcare human capital. Starting today, we're going to set the landscape. We're really going to look at the need that's out there, the opportunities that exist, and provide some data to set the framework for all of us. Next week, we're really going to discuss the graphic that you have on the screen, pipeline issues. We know that finding the people to be nurses or doctors or frontline healthcare workers starts early with interest in recruiting, works through an application and admission process. Obviously, folks need to get to graduation, get certified, and then ultimately get to where they are needed. And if we envision this as a pipeline, you've all seen the traditional funnel as here is on the screen. We know that that naturally narrows, but this pipeline has leaks in it. And certainly we're going to spend some time next week talking about how there are issues with recruiting and retaining folks, how there are gaps in actually graduating people and getting them to certification. And we'll talk about some examples of that. 2 weeks from now, we're going to talk about how this system, what you see on your screen, is interconnected to so many other issues, to issues of funding, to issues of diversity, to issues of working in systems and silos, and how that doesn't always work for people. And then in our final session at the end of the month, we're going to look at an example of a cross-sector partnership that's really breaking through on some of these issues. And then we're going to hear from reflections from some key industry leaders across our state about how they think their sector of the world, be it business or healthcare or higher ed, can really have impact. Following each of our sessions, actually following sessions 2, 3, and 4, we're also going to be sending out a follow-up survey and providing opportunities for you to weigh in, to ask questions in advance, to learn more, to raise your hand and say you want to dig in to more details, or to partner with others. That can be by topic. Maybe you're interested in nursing, or it can be by geography. Maybe you're interested in addressing these issues in the New Orleans area. We think both of those ways to slice and think about these issues are important, and we're going to try and pair people up going forward to engage in that work. Finally, just a couple framing notes. We are recording these sessions, as you probably heard. If you are watching on Facebook, you certainly know you can watch later that way. We are going to be sharing notes and information from these sessions, particularly this week, as we know so many people have ongoing gaps in internet service and in some cases power. We want to make sure folks can watch this later, because while now might not be the perfect time for folks to watch live, we certainly know that having the mental health providers, having the nurses, having the doctors we need is going to be critical for the long run. Last thing to say before we dive into today's session, I should note that these sessions can't begin to cover everything. We are dealing with a very broad topic, healthcare human capital. And rather than being designed to cover everything, they're designed to highlight some key ideas, to encourage ongoing collaboration and conversation, potentially to foster more conversation and work outside of these sessions. That's why we're going to send follow-up surveys and try and pair people up. A few examples of things we are not going to be talking about into depth, just so you're aware and so that you all can be thinking about how these might play themselves out. We're not going to dig a ton into pay and pay disparities. We know that whether it's pharmacists, nurses, doctors, there are key roles relative to pay and salary points that have changed over time, and that is impacting where people go, where people serve. We also know that there are some programs that are in high demand these days where the salary you may earn may not line up with the cost of training. So certainly that is something that we will touch on, but aren't going to get into a ton of depth. We aren't going to get into a ton of depth on interprofessional education, ways in which multiple different fields and sectors work together, work at the top of their license to meet healthcare needs of patients. That obviously requires creative thinking and collaboration, thinking beyond silos. We're going to discuss that to some degree, but we know there's great work happening on that across our state. We aren't going to touch a ton on telehealth and the role of digital health. Obviously, this is a virtual presentation. We're all familiar with doing work virtually, but certainly we know that there's all sorts of interesting ways to think about how digital health could impact the future. For example, maybe we don't have to solve all these same barriers that we're going to talk about. Maybe we need to be solving an internet barrier, and that becomes a way to extend care. So certainly something to think about. And then we're not going to touch a ton on the fact that healthcare is a gigantic part of our economy. These roles are good paying roles. They have personal impact for people and their families. People getting a nursing or another healthcare role can be a great economic opportunity for families and stability. And we know that many of our healthcare institutions are big businesses and communities. We'll touch on that some, but certainly there's nuances to go into. And I could go on and on. These issues connect with so many others, and we know that that you could pull these pieces apart from a variety of different angles. What we're really hoping to do in the next 4 weeks is to encourage you to think through these issues thoughtfully, understand how they align to your work and to the issues in your community. You are certainly always welcome to visit our website, bcbslafoundation.org, to learn more about these sessions, to learn more about our work, and we'll dig into details. Okay, that's enough of me talking. We had hoped today to be joined by Louisiana's Secretary of Health, Courtney Phillips. As I noted a few minutes ago, Louisiana was impacted by Hurricane Ida a week ago or so. And Secretary Phillips and her team are all out helping with immediate needs. We understand and respect that and are glad that they are there. Many of the comments that I just made relative to the overall state's needs are reflective of that welcome. And we're just glad that you all are here. We are particularly glad today to be joined by our keynote speaker, Dr. Luis Padilla of the Bureau of Healthcare Workforce, is Associate Administrator and Director of the National Health Service Corps, which are part of the Health Resources Services Administration, HRSA, under the U.S. Department of Health. Dr. Padilla works with many national and local groups to address exactly these issues that we're here to talk about, addressing workforce needs, addressing issues of equity, and ultimately ensuring that we're able to get the healthcare outcomes that we need by making sure we have the healthcare workers that we need. The Bureau of Health Workforce gives out approximately $1.6 billion in 40 different programs across the US. So chances are you've heard of some of these. Some of you may have worked with some of these. Dr. Padilla was appointed to serve as Associate Administrator in May of 2016. And prior to joining this work, he was Senior Health Policy Advisor to the CEO of Unity Healthcare in Washington, D.C., an FQHC network that was serving more than 100,000 patients. Dr. Padilla is a board-certified family physician. He has his BA in philosophy and BS in biology from UC Irvine, has his medical degree from Wake Forest School of Medicine, and completed his family residency at Brown University. Dr. Padilla, we are so glad you are here with us today, and we will turn the floor over to you for your presentation.
Thank you, Michael, for that kind introduction. And I think, thank you for turning on the video. Thank you. And thank you for that introduction. And a pleasure to be with you today. I know, as Michael mentioned, and not the circumstances that you were hoping for, but certainly welcome that we were able to have this session and I was able to speak with you today. And again, before I start my remarks, everyone here at HRSA, HHS, BHW, extend our well wishes to all of you in the aftermath of Hurricane Ida. We know that you're all struggling to get back on both online and get back into your, obviously many communities having to be displaced as a result of the hurricane. So our well wishes to you. And as always, I'm always amazed at how well Louisiana bounces back from these. Obviously, you're all very accustomed to this, but in the backdrop of the pandemic, certainly adding insult to injury these times. So best wishes to all of you. Next slide, please. So just briefly, I wanted to provide an overview of our work, what we do to address health workforce across the country. Some of those challenges, as Michael has already articulated several of the ones, and I was really happy to hear this next session that you're going to have in terms of the pipeline, because that's certainly something that we're doing in our work and really at the basis of our work, and that is developing that pipeline and that continuum of education all the way to service and practice in areas of high need. How we're building and supporting the health workforce across the country, and then looking ahead to some of the opportunities that we might have together. Next slide, please. Next slide, please. So as you look at our overall mission is to improve the health of underserved populations, particularly strengthening the health workforce and connecting skilled professionals to communities in need. And now more than ever, this is really, really important as we have more and more communities across the country that are struggling, not only with the pre-COVID maldistribution, shortage of key professionals and paraprofessionals, but certainly COVID has exacerbated all of this. But we strive to really lever this continuum, education, training, and all the way to service through our various programs. Michael mentioned we have over 40 programs that we use to lever our mission and our vision of improving the lives of communities across the country, particularly those in rural and underserved communities. Next slide, please. So just a little bit about what our overall aims of our programs are. Michael mentioned access, and I was really delighted to hear that the foundation is focused now more and more on access to care, because that's certainly the hallmark of our programs. It's important that our programs not only improve the quality of education and training that goes into our students, trainees, residents, but ultimately that by our work, we're increasing access to quality care, culturally competent care across the country. And we do this by focusing on the supply of providers and balancing the health workforce demand for services with the overall supply that we see across the country. But more importantly nowadays, focusing more and more on the maldistribution. Certain disciplines, we know that we have what we would characterize and have characterized as an oversupply of providers, but we're seeing an entrenchment in terms of the maldistribution of these providers going into certain areas where really you could make a case that they're not needed, as much as certain areas across the country where we have a desperate need for providers. And then ultimately, we're always striving to improve the quality of that education and training, but also to demonstrate how these workforce programs improve the quality of care that's being provided as a result of these programs. Next slide, please. So as you look at our focus areas here for the next year, and really for the next several years, our government-wide priorities include obviously COVID response and equitable response to COVID going forward. Certainly the Biden-Harris administration has made quite clear that it's important to have both in conjunction. It's not enough to respond, the federal government respond to COVID. It has to look for ways to improve the equity of that response and then overall health equity. But in particular, we're focused on two large areas. One is behavioral health. I'll talk a little bit about that and some of the new funding opportunities that we have targeted to improve provider resiliency, decrease burnout, and help organizations with their overall culture of wellness. But the other large item is community health. And enveloped in this is public health, social determinants of health, those things that are really drivers to improving the health and well-being of communities across the country. And we understand that there are cross-cutting themes that cut through these focus areas. I've mentioned provider resiliency. Michael in his intro mentioned telehealth. I know you won't be talking too much about that, but it is an important facet that's come out of COVID, and one in which we're really looking to lever, not only in the delivery of services, but in the education and training of our future workforce. And then ultimately diversifying the health professions is our way of, and we think it's an important driver of improving health equity across the country. So that's another cross-cutting theme that we're looking across all of our programs to better improve the health of communities across the country. Next slide, please. Next slide, please. So the challenges, and certainly Michael has outlined ones that existed even before COVID. There was a growing demand, and there now is an increasing demand for services. And in the backdrop, pre-COVID was a shrinking supply. We understood, and HRSA has put out projections of its health professions workforce and supply and estimates of that going back several years. And we do this on an annual, biannual basis. Right now, we're looking at by 2025, we have a shortage of nearly 24,000 FTEs of primary care providers across the country. And this really masks what I've said before is an unequal distribution of that workforce. Certainly there is some pressing shortages, but in the areas of nurse practitioners, PAs, and some other disciplines, what we're seeing here is a really pressing need to address the maldistribution of those workforce workers in those disciplines in particular. Next slide, please. So in order to address it, and I've mentioned already that we put out projection reports in terms of demand and supply, but we also designate health profession shortage areas. So a little bit about this, because I think this impacts Louisiana in particular. We provide the designations for dental, primary care, and mental health profession shortage areas. We do this by designating geographic areas, facility types like FQHCs, or population groups like homeless populations, special populations. But these are designations to demonstrate a health profession shortage area. But we also utilize within some of our HRSA programs, medically underserved areas or medically underserved populations that demonstrate a need for certain services, and in particular primary care services. And these two demonstrate a need for certain services in geographic areas or in certain key population groups. Next slide, please. So here, just showing you a national picture here of primary care shortage designations across the country. The darker area means that there's a greater shortage of providers. The lighter area, obviously, less so. And you can see here what we've been seeing here for several years, and that is in certain areas, the shortage of providers is really stark, and in some areas less so. But we can make claims that throughout the entire country, there is a need to improve access to care and therefore improve the number of health professions that are in those areas. Next slide, please. Likewise, in mental health, here are the pictures even starker. As we look across the country, there are more areas here with some significant, and counties in particular, with some significant shortages in mental health providers, particularly in psychiatry, child psychiatry, and addiction medicine providers. Next slide, please. And obviously here in dental health, less of a darker picture, if you will, across the country, but you see some areas here with some really pressing needs in terms of oral health. And so when we look across the country in terms of these three areas, primary care, mental health, dental health, we see a pretty dire picture. And certainly in Louisiana, the reality in terms of what you're needing, what you're seeing, and the access to care is certainly no different. You do go to the next slide, please. Show you where you are in terms of primary care, mental health, and dental health. So I don't think it's a surprise to any of you on this call, the dire need that you have for mental health services, oral health services, and primary care services throughout your state in all of these counties here where we're projecting or we're designating here pretty significant shortages. Michael in his intro mentioned that there was a request for 6,000 direct healthcare workers. We estimate to just bring you to baseline, we're talking pretty close to 500 providers divided into each of these domains that you would need to start addressing the need in your state. Next slide, please. Next slide. So our strategies for addressing these shortages, not just in Louisiana, but across the country, really encompass a lot of elements throughout our various programs. Overall, what we're striving to do is recruit more students, more residents, more trainees from the communities that they serve. I think all of you are familiar with the literature that shows that the more that you can do this, the more likely you are to have those students, those trainees remain in those areas. When we try to place students from one geographic area in the next, I think that's a temporary solution. What we've often seen is there tends to be a migration and recruitment issue after those students, those professionals acclimate to that area, but it's not conducive to their needs for whatever reason. So we have found, and the literature supports, that the more that you can do from recruiting from your communities, the more likely that you're addressing these pipeline struggles that you're having. This is particularly true in rural and underserved communities. And this is something that we've been very focused on the last 5 or 6 years, is trying to have students have more longitudinal exposure in rural and underserved communities in the hopes and by incentivizing them with our loan and scholarship programs to keep them in those communities. Regarding our loan and scholarship programs, we've been intentional in linking our health professions grant programs to these loan and scholarship programs. We've provided priority awarding for our National Service Corps loan repayment programs in our Teaching Health Center GMA program, which I'll speak to in a little bit, our addiction medicine program, and then shortly will be a priority for our nurse practitioner residency programs. We feel as if this is an important added dimension to our programs in that we understand that there's crushing debt after you get out of professional health professions training programs. And we believe that these loan repayment and scholarship programs will help to ameliorate some of that and also to address some of that maldistribution that I was speaking to earlier. Next slide, please. So Michael was mentioning the pipeline programs, and certainly we do quite a bit here. Our 4 programs have been around for decades, 30, 40 years in terms of our area health education program, our Centers of Excellence program, our Health Careers Opportunities programs. And over the years, it's done quite well. Just this past academic year, we've provided support to over 335 participants and trainees through these programs. A number of them come from underserved, underrepresented minorities. Many of them come from rural backgrounds, and the vast majority of them get training in medically underserved communities. Again, stressing that area of longitudinal exposure for these students and trainees into areas where they're needed the most. Next slide, please. But in addition to that, we've been stressing over the last few years our postgraduate training, and in particular our community-based training. And this graph just gives you an idea here of where our focus has been, particularly around medically underserved communities. You see now here the last few years from 2016 to 2017 to now, we've increased about 8 percentage points in terms of the setting in which our students and trainees receive their training. We're going to continue to lever this. As I said before, this is an important vehicle to utilize. We support academic and community-based partnerships that do more and more of that setting-specific training, which we think is such an important part to getting workforce directed where they're needed the most. Next slide, please. So one of the efforts that we've undertaken in Louisiana, I'm happy to say, participated in this as well. Last year, we partnered with our sister bureau, the Bureau of Primary Healthcare that oversees our health center programs, and put out a request to complete a survey that one of our awardees had developed. It's a standardized readiness to train tool, and the effort in the hopes of this was to have more health centers not just complete this tool, but get on the path to creating workforce and implementing workforce development action plans. So this first year, we had over 8,200 responses to the survey. That's a 73% national response rate among all FQHCs across the country. Louisiana, I'm happy to report, had a response rate of about 45%. So that's great. So where we are right now in year 2, our contractor is completing the analysis of those results. They're going to send out those results to every single one of those health centers that completed the response, along with their primary care associations, including those in Louisiana. We're going to start fostering those partnerships between academic institutions and community-based organizations in the hopes of increasing their capacity to do more education and training. So when you talk about pipelining, it's really important to support the infrastructure that's necessary to do more education and training at the community level. By year 3, our expectation will be through this funding that we're going to implement workforce action plans, development action plans in each one of those health centers. We're going to disseminate the evidence-based models and promising practices that are being implemented throughout those health centers, and demonstrate sustainability and return on investment. We understand that education and training is not just labor intensive, it's financially intensive, particularly if you're training residents in graduate medical education. And we hope through this effort, we'll be better able to target our funding to address some of those barriers that have been identified through the Readiness to Train tool, and put health centers in particular and safety net organizations in a better footing to do more education and training within their organizations. Next slide, please. So again, this what we call the HPET, the Health Professions Education and Training Initiative. The expected outcomes is to engage permanent PCA staff to help implement these health centers work plans. That already began in the first year of the project. Determine health centers' level of readiness, and the first round of this is going to provide not just the information, the data, if you will, but also a score of each of those health centers' level of readiness to do more education and training. And most importantly, identify those potential barriers to doing more education and training and creating that pipeline. And that's going to help us and those organizations better tailor their partnerships and then hopefully improve their capacity to do more education and training. Next slide, please. So as we look at one of our marquee programs, our Teaching Health Center Graduate Medical Education program, this really is the model by which we look at many of our programs. It's community-based, it's a residency program. It is outside the CMS's cap for primary care. So every resident that completes this program is above that CMS cap that was established in 1996, I believe. Unfortunately, Louisiana is currently not an awardee of this program. And I'll talk a little bit more about the opportunities that Louisiana will have as we've gotten additional funding in the amount of $330 million. We've already put out the first round of that funding this year. We're going to put out another round of funding next year. And we anticipate that this well-received program is going to get additional funding. So I would encourage you in Louisiana to take a look at this, take a look at how you might be able to lever a program like this, and then come in for the next round of funding. It certainly has shown itself to be very effective in increasing the number of primary care providers. It does support oral health. It does support OB-GYN residency and psychiatry programs. And really what the difference between this and the CMS program is really rooted in the community. These are community-based training programs. Unlike many other CMS JME programs that are really heavy on hospital training, this is the focus of this is really community-based primary care training for these residents. Next slide, please. So as I mentioned, the American Rescue Plan gave us an additional $330 million. We've already put out 3 funding announcements related to this funding opportunity, this additional funding, two of which have already closed, one of which is closing on September 21st that will expand the number by 85 new additional awardees, the number of residents that we train. When this funding is complete, we anticipate that we're going to have pretty close to 1,400 FTEs of residents trained through this program. That's nearly double the number that we're supporting right now through our current funding. Next slide, please. Another program that I wanted to highlight, again, in community-based training, postgraduate training, is our Advanced Nursing Education Nurse Practitioner Residency Program. We've made some changes to this program several years ago that really restructured this program to be more community-based. We know that residency programs, fellowships are not a requirement within nurse practitioner training, but we felt and heard from our stakeholders that it was really important to have additional training, particularly as we start to look at the what we characterize as an oversupply of nurse practitioners across the country. This program is really helpful and will be lever to address some of that maldistribution. Over half of the students or the residents who complete this program either stay at the site where they're training or go work in other medically underserved areas. So really an important part of our overall strategy in increasing workforce in rural and underserved areas. Next slide, please. So the other program I want to highlight here is the National Service Corps. It's our largest standalone program right now with the American Rescue Plan, over $1 billion dedicated to loan and scholarship awards, in addition to the Nurse Corps program, which received another $200 million through the ARP funding as well. But the National Service Corps program has really grown over the last 50 years. It's been 50 years since it's been enacted. Over 60,000 members have completed training, but not training, but completed their obligations. Right now, we have over 18,000 members in both of these programs, the largest field strength that we've ever had in these programs. And we are going to end our current round of awarding this year, which will increase that number, and then next year complete our overall funding of the $700 million that was awarded to this program. So all in all, by the end of next year, we will have an excess of 20,000 members in this program. Again, the largest complement in its field strength ever. And really a program that has been utilized across the country, not only to recruit, retain, but also to increase the pipeline through our scholarship programs of the professions that we support through this program. Next slide, please. As I said, the National Service Corps has current funding opportunities out. Our one that we just put out earlier a couple of weeks ago is our National Service Corps Student Service LRP. That targets fourth-year medical students, dental students. This year, in FY22, it's going to target physician assistants and nurse practitioners during their training to encourage them to go into rural and underserved areas. Starting in fiscal year 22, we are going to launch our state loan repayment program. I believe Louisiana takes advantage of the state loan repayment program. This additional funding is going to allow states to utilize and free them of that administrative cost that currently is typically tied into this funding, to allow them to lever this additional funding through the ARP to increase their state's complement of awards through this program. Next slide, please. So we put out a lot of funding, but we also feel it's important to help connect those clinicians to areas of highest need. And we've been doing that for several years now through this portal, the Health Workforce Connector. And if you're not patched into this right now, I encourage you to do so. We provide virtual job fairs. Some of these virtual job fairs are attended by over 1,000 job seekers, with hundreds of employers looking to connect clinicians to their organizations. We now have over 30,000 sites there, primarily Nurse Corps and National Service Corps sites, but we're expanding the footprint to include other sites as well. So really an important tool to take advantage as you're trying to recruit individuals into your health systems and organizations. Next slide, please. And a little bit about it, I know that your sessions won't be talking about interprofessional collaborative teams, but we certainly do take that that active step to incorporate interprofessional training through all of our health professions program. We believe that integrating behavioral health and primary care, public health and primary care are an important vehicle for us to have not only well-rounded individuals coming out of these programs, but providing really competent interdisciplinary care throughout our programs. Next slide, please. So in particular, I wanted to highlight the apprenticeship component to our behavioral health programs. We launched that in our paraprofessional programs that we launched last year, and we'll continue to leverage this component of our health professions training. It improves productivity, cost effectiveness, it creates flexibility, and more importantly, it creates an employment avenue for those students that we train through our behavioral health paraprofessional workforce programs. So certainly something to consider as you're looking at Louisiana's workforce efforts. How are you leveraging apprenticeship programs throughout your pipeline programs to really take advantage of the positive aspects of having apprenticeships within health professions training programs. Next slide, please. And just a little bit before I end here, I know I've talked a lot, but I can't say enough about the importance of workforce resiliency. We've put out just a little over $103 million in the last few weeks. This funding opportunity is closing, all the funding opportunities here that we put out, closing September 20th. They're meant to improve resiliency and mental health among health professionals. They're meant to support organizations in their culture of wellness. And they're meant to support a technical assistance center that's going to disseminate best practices and support these awardees through the period of funding. It's not enough. As I'm sure you'll talk in the next 3-4 weeks, to recruit individuals. How are organizations supporting their workforce within their employment environments and trying to keep them there, whether it's through multidisciplinary approaches, team-based care, or the support staff that is around those clinicians that really drive that clinician's decision whether to stay within that organization or leave. And obviously COVID has brought to bear the reality that resiliency, burnout, is a definite reality and a negative outcome of not just COVID, but healthcare in general. And I think this funding opportunity allows us now to enter into the space. It's something that we haven't done before in the Bureau of Health Workforce, but I think it is now both a welcome part of what we're doing and a much needed part of what we're doing. Next slide, please. So looking ahead, talked about our health center readiness training readiness tool that's going to go out, and the data that's going to go out later on this year. Clinician well-being, workforce coordination continues to be an opportunity for us to coordinate, not just within HHS, but across the government, whether it's with our apprenticeship programs or with other organizations to help coordinate workforce needs across the country. But these challenges that are highlighted here continue. COVID is here with us. The Delta variant, unfortunately, is unrelenting. We're going on 2 years now of this pandemic, and it's having us to relook the way we structure our programs, the way we engage with our stakeholders, and the needs that are not quite clear right now. Even though we put out estimates of health professions supply and demand, we don't have a clear picture right now of the impact that COVID has had on the workforce. We're going to start looking at that as data comes in, and we utilize that to get a better picture of how exactly COVID has impacted our overall workforce needs across the country. Let me stop there. If you go to the next slide, I think I want to allow enough questions or enough time for some questions on your part. So with that, Michael, I think I'll hand it back to you. Thank you so much.
Thank you, Dr. Padilla. We appreciate it. As folks have questions, please don't hesitate to drop them in the chat, either if you're here with us on Zoom or on Facebook. We've got one in chat. I've got a couple here in front of me, and we'll try and get to as many as we can. Dr. Padilla, can you talk, you touched on certainly how COVID has accelerated many of these issues. I know the data is a bit murky, but are there places across the country that may be bright spots or that you think are worth highlighting that are doing a really good job of sort of navigating what have been crazy turbulent waters that you think when Louisiana looks around, we ought to sort of, maybe look at some examples that could be of interest to us?
Mm-hmm. Well, certainly before COVID, I think that probably would have been a rosier picture. I think all states right now are struggling with the surge needs within their states. That said, though, I would highlight a couple of states, 2 or 3 states that we think even during COVID, have done really an outstanding job of mapping out their workforce needs, relating that to the available data, and engaging with their legislatures on having some dedicated funding to address their workforce needs. Those would be Massachusetts, Indiana, and California. And in particular, Indiana has gone a long way in looking at its workforce data. Before, and Louisiana might not be in this position because of so many of the designations that are currently within the state, but before it undertook its efforts in Indiana, there were a lot of counties that weren't designated. And it's because they didn't have a good handle on their overall workforce data. So they work with their primary care associations, their primary care organizations, to get a better handle on that data, resubmit some of their designations, which increase, and yes, it increased the number of health professions designations, but it gave them a better, clearer picture, truer picture, if you will, of their workforce needs. California, I think, has been exemplary in engaging with their legislator to have some dedicated funding to develop a coalition of workforce experts within their and partners within their states that have had them focus particularly on graduate medical education, but also create a consortium that looked at not just their pipelining, but also their safety, healthcare safety needs and organizations, including FQHCs and others. So I think those are just some states that I would say, I think they're doing a pretty good job despite COVID in moving forward and addressing some of their workforce their workforce challenges.
Thank you. We got a question in the chat about training for HRSA programs being done in Louisiana. Obviously, folks can go check out the HRSA website to find out more about particular programs, but are there places you would point a hospital or a higher ed institution who wants to learn more within the state of Louisiana for particular programs or trainings that are being done? Is there somewhere you'd point folks to?
Yeah, I'd have to get back to you on the specifics of where we have a lot of our training is not going to hospitals per se. It goes to academic institutions, community-based organizations that are doing that education and training. So I think there are likely a number of organizations within your state that are safety net organizations that are taking advantage of our funding and building that capacity out. And I think this is one of the efforts that we're undertaking with the primary care associations, even within Louisiana, is what is happening within your states. And that was really the intent behind that survey that we deployed last year, getting a better understanding of where health centers in every state were in that trajectory, in that continuing, if you will, of education and training. So I'd have to get back to you on what are specific organizations that are doing a lot of the work or taking advantage of our particular funding to lever it and address their workforce needs in Louisiana.
Makes sense. Thanks. Your presentation, I think, presented really good high-level overviews of the data and the programs and the ways that folks can potentially engage. Can you share some, I guess, insights if I'm listening to this and I'm not one of the traditional stakeholders? I'm not a nurse training program, or I'm not a hospital administrator. Maybe I'm a nonprofit that recognizes this is impacting the health of my community. Or maybe I'm a foundation that wants to grant some money to address health issues, but hasn't necessarily thought in these lanes. Can you speak to some of those audiences about why this question of healthcare workforce is critical for them to think about, both in the short run and the long run?
Well, I think you sort of laid out that framework in terms of access. And if you're going to address access, you're going to have to address your workforce needs, your workforce development needs, whether it's in an organization, in a community, in a state, or even nationally. There just simply isn't any way to increase access of services without a commensurate increase in that workforce. I think the struggle that we have is, where is that workforce coming from? And I think what we've determined is it's unlikely to come from other states into Louisiana, if you will. It's going to have to come from within Louisiana, within California, within Massachusetts, to build their infrastructure, to maintain their trainees and students within that state. And we've seen this time and time again, Michael. You have medical schools in Louisiana. You have nursing schools, you have PA schools. So there are academic institutions that every year put out hundreds, if not thousands, of graduates from those programs. But where are they going? And why aren't they staying in Louisiana to provide services to those communities that are needing? And that's really the bulk of our work, is getting a better understanding of what's happening there, why that's not occurring, and what are some of the remedies that certainly at the national level. So I would say, if you're interested in increasing access to care, you're going to have to look at workforce. And I just simply don't think that you're going to have any effort or any long-term success in any outcome, whether it's a quality outcome, population outcome, without really addressing workforce needs as a part of that strategy.
Makes sense. Earlier, you gave, I think, a number which I jotted down, 24,000 primary care providers, I think was what you outlined as being necessary across the country. I imagine there's other similar stats. I mean, we're certainly short primary care providers, we're short dentists, we're short mental health providers. Can you run us through some of those? Because I imagine we have at least a few friends who are watching this who are thinking, okay, that headline is important for folks to understand. Obviously, Louisiana has our own number, but a number of that size, I mean, we have big football stadiums in Louisiana, but that's a quarter of Tiger Stadium in terms of the number of doctors that we need or primary care providers. So can you run us through some of those numbers in terms of the scale of need, just so people can start wrapping their heads around, we got to chip away at this?
Yeah. Well, and again, we've laid that out back in, and that's up to 2025, I believe, 2030. We're updating those estimates now. We're trying to get a better understanding of the impact that COVID has had on that workforce. It's not likely to be, fortunately, because of deaths in the healthcare workforce. It's more likely to be of attrition, people leaving the workforce. We've seen that now in some of our programs where the applications have somewhat decreased in the last year. Not a huge amount, but it's giving us an indication that COVID is having an impact in terms of attrition. In oral health, the number is not as large, but you're talking in excess of 6,000 FTEs in order to accommodate all the oral health needs across the country. And again, I think what we have to understand is that this really has to be a regional sort of effort, because nationally we may say, well, there's X number, but in Louisiana or in on the West Coast, Midwest, the needs proportionally may be dire, because in those particular states, again, you're suffering from that maldistribution area, that maldistribution effect, if you will. So we know that there are individuals being trained in certain states, and they're just simply leaving that state and leaving those states with a greater need. So about 6,000 oral health providers. We have about anywhere from 6,000 to 8,000 mental health providers in particular disciplines that we know we're going to be short. And I think that all of this, Michael, really has us thinking about what can we do to lever all of these disciplines across this continuum, because trying to get 25,000 more primary care providers is going to be a tall order for us. But how do we lever nurse practitioners that we project have an oversupply, right? So programs like our Nurse Corps program that provides loan repayment and scholarship to go in a particular area, or a National Service Corps program. So wherever we have the ability to either require, incentivize certainly the trainees and students that we support through our funding, we want to continue to do that, to try to drive that workforce where they're more needed. So that's just to paint you that ugly picture, if you will, nationally of what we're looking at. But again, Louisiana may be worse off than in other states that are able to keep that workforce there.
Absolutely. And from the data you showed earlier with the graphics, I know Louisiana's not in great shape on many of these points, and certainly with issues of rural and low income, we know there are just real challenges. You touched on something that obviously we're going to touch on over the course of the next couple of weeks, which is addressing these issues on sort of a regional basis, sort of thinking about how to meet the needs of a community or a set of nearby communities. Anything you would want to sort of highlight if I'm looking at some of our partners who are attending, who are primary healthcare providers, or who are higher ed institutions, or who are philanthropists that have a specific geographic focus, other than partnering with the folks in your area and trying to get a handle on this, thinking about tools, et cetera, are there other things you would highlight as you really ought to think about doing X, Y, Z? I know you touched on making sure folks who you train aren't leaving and going somewhere else. Anything like that or beyond that?
Well, I think overall your efforts, and I commend you on this series of discussions, because I think it is really important to start thinking of Let's look at the data. Let's look at what's really happening within the state of Louisiana and starting to build that framework for that pipeline. So, the efforts that you're going to be undertaking right now to talk about recruitment, the admissions, what is preventing individuals from successfully graduating from these programs, and then how can we keep them here in Louisiana? I think you're on the right track there, and I think it's going to require you to take a really serious look at how are you admitting these individuals and who are you admitting, because if academic institutions can't seem to, or for whatever reason, and we know that there's a number of reasons and challenges, to look at their admissions in a different way, particularly now with such crushing needs in Louisiana, then I think you're going to continue to be in that wheel of production, loss, production, loss, production, loss. And I would say that, I'm happy to share some of the examples I got in California, UC Davis, where they, for the last 10 years, have been very intentional on the partnerships that they form. So it's not just enough to say, hey, we're going to go sign this MOU with this organization, but what is this organization about? What is their mission? Is that mission in line with the mission that we're after here? Because if it's not, that partnership is likely not to be as effective as if you had a like-minded CBO or community-based organization that says, no, we are interested in diversifying our workforce. We are interested in creating our own pipeline. We are interested in getting you students that you will admit to your health profession school that are ultimately are from this community, understand our community, and are going to come back and provide services to our community. And I think that's one of the exciting things in work that we're after is how do we build that infrastructure and support for those partnerships to exist and expand and grow.
Absolutely. Well, with that, I want to say thank you. Do you have any final closing comments? Anything you wanted to touch on you didn't say?
No, just thank you so much for I'm excited that you guys are doing this over the next 4 weeks. I think you have an exciting agenda, and I think you're touching upon all the things. I wrote some notes down that conical graph that you have is exactly what we call it, slightly different things, but it's exactly that. You're looking at each layer and saying, let's look at each layer, because when you get down to that tip, there's not a lot that you're hiring, particularly from these communities. And I can't stress that enough. And we see some of the effective models across the country really levering that idea. How can we grow our own? How can we train our own? And how can we hire our own as best we can? So thank you for the invitation to speak.
Absolutely. Well, Dr. Padilla, we really appreciate you joining us today, and we appreciate all of you joining us today. I'm going to wrap up today's session by saying thank you for your questions, for your insights dropped both on Facebook and here on Zoom. We have been recording this session, and we'll be sharing those materials, as I said at the beginning, recognizing that so many folks in Louisiana are still struggling to get back power and internet. We know that this may not have been the time for everybody to engage, but we think the topic is critically important as we shared today. Next week, as Dr. Padilla touched on, and as I shared at the beginning, we're going to be gathering again Tuesday, September 14th at noon. And we're going to be hearing about 3, we think, really innovative examples for addressing some of the pipeline related issues. We're going to hear from an example of an early exposure fellowship that's specifically working with diverse populations of low income kids, to expose them to what primary care medicine looks like in high school, and helping them to set them on the way with scholarships and other training and supports into college and mentoring programs to increase the diversity of healthcare workforce. We're going to hear about examples of wraparound services that a university is doing, we think, in a really exceptional way to dramatically increase the number of students who not just start, but actually work their way all the way through to graduation, and graduate with that degree to go into a targeted set of roles. And then we're going to hear about a really interesting example coming out of New Orleans, but covering the whole state to address some of the final hurdles that many of us don't think about. Most healthcare roles require residency or preceptors or supervisors. And when you have a shortage of those, that can be a gap that prevents somebody from actually finding their way to a role that is needed. And so we're going to be highlighting some of that as well. We hope you will plan to join us again next Tuesday, September 14th at noon. You can register for that session in the same way you did for this one. Certainly, if you have questions about any of it, don't hesitate to let us know. For now, I will say thank you again for your time and insights today. Thank you again, Dr. Padilla, and to everybody who participated. We really appreciate it. We hope you all stay safe in the days to come, and we look forward to talking with all of you next week. Have a good day, everybody.
Hi, Michael. I don't know if you're still on.
I am.
Oh, can you hear me?
I can. Can you hear me?
Yes. Well, thank you very much. I don't know if there was anything you wanted to debrief on, but certainly if there are any other questions that